Also, welcome from my side. I'm excited that we have another MDT webinar that we can exchange among each other over the distance and continents. I'm very happy that we can welcome Eva Wardelmann as a pathologist from Münster, Germany. Then the second speaker will be Mohamed Kelaney, medical oncologist from Cairo, Egypt. And last but not least, Robert Turcotte from Montreal, Canada, as an orthopedic oncologist. Again, I'm very grateful that we have these highly known speakers to us with a vast experience in sarcoma care. And the goal of our MDT exchange is, of course, to see how patients are cared in different countries, in different continents. From this standpoint, it's very special that we have speakers from 3 different continents today. Please feel free also to be a member of the panel discussions in the future. So it's just open for everyone. We are more than happy to welcome whoever wants to contribute and to foster exchange. In this context, I think we just start and we hand over to Eva. Please present your case.
Yes, hello everybody. It's a great pleasure to be here. And I was, of course, thinking what could be a nice case for this round. And let's move on. And I will also ask you some questions. I don't know whether you are able to answer just because of technical reasons. However, let's go ahead. It's a young man. He's a rapidly growing tumor on the shoulder. And first presentation was in November 2020. And this is the clinical aspect. As you can hear from it's already a large tumor presenting at the skin, and that's a shoulder. And the patient had this, ulcerated process only a few weeks, and then showed up in the clinics for dermatology. There, the tumor was resected. Of course, there are different possibilities what this could be. I mean, a melanoma, of course, would be interestingly ulcerated, carcinoma, lymphoma, sarcoma, inflammation, everything is possible. So the second question is what to do next, whether it should be useful to make a biopsy. Of course, as pathologist, I would always support to take a biopsy. Or should we do a primarily tumor excision? If a tumor is not so large, of course, someone could say we excise it, and this is already good to make then the diagnosis on the tumor excision. As we have recast here, we could also irradiate upfront. We could do chemotherapy or combine these 2 issues, or we could just wait and hope that it goes away. Well, this is the morphology, the H&E staining of the lesion, which was primarily resected without biopsy upfront. And you can see already that there are mitosis. I show one here. This could also be apoptosis. There's another one. And it's an epithelioid lesion with big stomachs of the tumor cells. They have an eosinophilic cytoplasm. And well, nuclear pleomorphism is not so extensive, but we would already suspect it's very cellular, that this is probably a malignant lesion. Let's move on for the immunohistochemistry, which normally solves a lot of problems for pathologists. But in this case, and this is why I wanted to present this one, we have a pattern of staining, which is a little bit disturbing, because if we just see the CD30, for example, we could say, oh, well, this could be a lymphoma. Why not? Anaplastic large cell lymphoma. If we see the ALK, we could think this could be an ALK translocated lesion or even also a lymphoma. The cytokeratin is so strong that we could think of an epithelioid sarcoma, but we have also desmine, which shouldn't occur either in lymphoma or in carcinoma, not in this extent, and also not in epithelioid sarcoma. So, well, what pathologists always do in this situation, they continue to stain more and more. And I will not show you all the immunohistochemistry we did. It's, I think, like 40 different stainings. I'll just show you the next one, which was a little bit surprising. And this is MyoD1. MyoD1 we use normally to identify rhabdomyosarcoma. The interesting thing about this case was that it was positive for MyoD1, but negative for myogenin. So the problem was what to do now. And as the lesion looks isomorphic, more or less, from the nuclei, we should always think whether this could also be a translocation. So what we did next was RNA sequencing, and it turned out to be the right way to identify what it is. But first of all, if we have epithelioid mesenchymal tumors in the skin, if it is mesenchymal, then this is normally what we find in the WHO classification. It's a long list of different tumors. We decided already that this is probably malignant. So if we just take the malignant ones, this is what we have. And if we want to stick it now in one, two of these sub-entities, it doesn't work out with the immunophenotype we have just seen. So, well, let's move on and see what the RNA-seq brought. And this is what we found. We found a fusion of EWSR1 with TFCP2. And, well, this is a rare fusion, of course, because it's a rare entity. It's an epithelioid rhabdomyosarcoma with this typical translocation. And for those who do not know, as me, TFCP2, what is it? It's a transcription factor, as often in the fusions we find in sarcomas. And it binds to alpha-globin promoter and activates transcription of this gene. So interestingly, now we have to find out what is about this case, what it's about prognosis, what to do clinically. So I will move on. But I just show you a report several years ago showing 2 cases and selecting all the others from the publications. There is now another publication out with, I think, about 40 cases. But as you can see, it seems to be more younger patients having these lesions, although there are some older ones also, but normally younger adults. We have normally trunk followed by proximal extremities, which is with shoulders fitting, and also head and neck region. Other regions are rare, more females than males, and a very aggressive biology, as you can see from these overall survival curves. So it's a really bad diagnosis. Let's look for EWSR1, because you know it's a fusion partner of a lot of other genes, and this always results in different diagnoses. And we often see tumors where EWSR1 is exchanged by FUS, which can alternatively be fused to the same partner and then also leads to the same tumor. This also holds true for this rhabdomyosarcoma. This fusion that we just saw can also occur instead with FUS. So it's again a tumor having the alternative EWSR1 or FUS, and then fused to the TCP2. What we can now say from the follow-up, I asked the clinicians, I got the last X-rays this morning, I have to say, and they sent me that the patient had a short time after the primary diagnosis had lung metastasis, and as you can see from the spine, a lot of bony metastasis also in the head and other bones. So it was a really rapidly progressing disease. There has been recently a publication about this specific group of sarcomas, either FUS TFCP2 or EWSR1 TFCP2. And what they could show, it's a very nice paper, but just to wrap it up shortly, they found on one hand, on the RNA sequencing, that these specific rhabdomyosarcomas do not cluster with the conventional, whatever it is, rhabdomyosarcomas, and that they also have separate methylation patterns compared to other rhabdomyosarcomas, either if you take embryonal, alveolar, or MyoD1 mutant rhabdomyosarcomas. So it seems to be that this is a novel tumor group, although interestingly, at least in the DNA methylation analysis splitting again in different families, whatever this means. So what was happening with the patient? He had the local resection. Then in April 2021, he was irradiated. We will have a comment on that from Rick, I suppose. Then he got 4 months later, got lymph node metastases, which were resected here in our surgery. 2 months later, there was done a CT from thorax and abdomen with no evidence of distant metastasis. Everybody was happy, but 2 months later, he had already a local recurrence, a big one on the shoulder, which was again resected and covered with split skin. And then another month later, an MRI due to pain from the spine showed this diffuse bone metastasis you've already seen in the X-ray, and also a fracture in LWK1. Oh, here's a little bit German remaining. Very nice. For those who can read it, there were some awesome bony metastasis in the bone of the head. No brain metastasis. So the patient got a systemic chemotherapy, got an acute renal failure because of the bone metastasis. He had a hypercalcemia due to these destructive lesions in the bone. So then he got some medication. He had also hypokalemia, and this was the first cycle of doxorubicin and ifosfamide in February 2022. But the bony metastases were progressing, and he had also lung metastasis, so palliative care. And as far as I could find out, he died a few weeks later. So really bad case. And I think we have to put into the skin WHO also this new group of tumors, rhabdomyosarcoma with TFCP2 rearrangement, either with EWS01 or FUS. And my take-home message is that many novel translocations lead to novel entities. This is especially sometimes difficult for pathologists, because if we get a new translocation, we always have to find out whether this is meaningful or just an accident, because translocations can occur in a lot of tumors. So I would suggest, if you've got more than one case with the same translocation, but you cannot find it anywhere in any of the numerous websites, think of publication. And on the other hand, we have to be aware that not every fusion transcript is meaningful, because I think the estimation right now is that about 50% of all translocations are just accidents, but are not meaningful from the function. Okay, so this is my case, and I hope you have some questions left. Yeah, thank you.
So thank you so much, Eva, for this very impressive presentation. I think first we want to stick to the pathology. I see that Gunhild is also among us in the panel, and Beate, I think that you first have to comment. But I saw that also Peter Nielsen is here, Peter Bode, and Thomas Knösel, so feel free to join or to ask your questions. Maybe Gunhild, do you want to start?
Okay, thank you, Eva, for this amazing case. I think it's very important to pay attention to such a rare case. My question or comment would be, I think these tumors were initially presented in the bone and then in the soft tissues. Do you have any idea how frequent in an entity which is not so frequent they are primarily manifesting in the skin? Or could it be that this was a metastasis?
Well, the idea is good, because as we have seen, there were so many bony metastases, so that could be a first hint that it was a primary from the bone, which wasn't identified. On the other hand, and when this patient presented with a skin lesion, he had a first staging. So I suppose that in that staging, they would have identified those bony lesions if they have been there in the upfront. However, you're completely right. There are some case series presenting these lesions in the bone. So I cannot give numbers, because the largest published series, like this paper I showed, have 12 patients, for example, and all the others are also not so huge series. So I think we have to collect up to 100, and then we can make some more numbers or percentages.
Yes, thank you, and you're really right.
Beata?
Well, great case, interesting case, and makes you think about, what did they call those tumors like 20 years ago? Because they were definitely out there. So
Yeah.
I presume probably, we had half of the immunohistochemical markers we have now. So probably MyoD1 we wouldn't even have detected. So, I would have diagnosed it as a melanoma or whatever. So some kind in the skin based anyhow. So it tells you, how the changing tools, changing the spectrum of the tools pathologists have also influences the distribution of the tumor types, I would say. So this is, like all the studies published some years ago or some decades ago may contain some of those tumors. So this is really, really interesting. And also, makes you also think about how come, this translocation activates the, production of desmin and MyoD1, and, it doesn't really have anything with Raptor. So I think sooner or later we'll end up, giving up those rhabdomyosarcoma part of the title, which is already started in the current classification. So let's see how it will proceed. What do you think about the future of the nomenclature?
I'm not sure whether this name will persist, because I absolutely agree that a tumor without myogenin normally cannot be rhabdomyosarcoma, because normally we say rhabdomyosarcoma at least has to have myogenin, and this one hasn't. So it might be a misnomer, and we will find out whether we have to give another name. What I learned about this case, which I had to present for a dermatologist meeting and was completely fascinated, was that in the skin, there are several different tumors able to express ALK, for example. So it's not so unusual in skin tumors to look for ALK and then to diverse diagnosis. This one is, of course, the worst one. And what I also learned, not only from this case, but also before, that if I have a desmin positive case, I will always look for rhabdomarkers, although it most often turns out to be some lyo, myo, whatever. But I think it's just important to think of rhabdo if you have desmin in a tumor. Even if this one looked already rhabdoid with these epithelioid tumors, but sometimes they are much more spindled, and then you might not think of rhabdomyo tumor.
Yeah, that's a good point. I always, people tend to skip SMA or smooth muscle actin, and there's this balance. If there is no SMA and a lot of desmin, it's always Raptor. So it's worse. Absolutely, what you said to go for the market.
What we sometimes discuss here, it also shifts from months to months, I would say, which are the best markers for leiomyosarcomas. And we nowadays, I would say caldesmone. So I would always, me personally, I would always make 3 markers for lyo, and then even if they are positive, would add these myogenin and MyoD1. But this is, I think we do not always have the same algorithms. So
I think in this context, Thomas Knösel from Munich, he asked, is the immune histochemistry always typical? So maybe you can elaborate based on what you already said.
I think, Thomas, you mean the immunohistochemical in this chemistry in this specific tumor entity. Well, we do not have these large series, but it's rather typical that we have got ALK, and it has been shown also in this Nature Communication paper that there are reasons why ALK is upregulated through transcriptional activation. Don't ask me details. So I think the profile is more or less the same in these entities. This is why they were grouped together. So it's not only the fusion, but it's also the expression pattern. So what I think is important, if you've got, for example, CD30, where you normally think of lymphoma, you should always think it could also be a mesenchymal tumor. And same was true for ALK.
Thank you. I think in this context, we want to also maybe pass the word to Meng Welliver, radiation oncologist from Mayo Clinic and recast, I think that might be important to address this issue as well. Who wants to start?
Dr. Haas, please start.
Why not you? Okay. Obviously, the indications for radiotherapy in the setting of non-retroperitoneal soft tissue sarcomas are either pre or post-operatively. In the retroperitoneum, if chosen, it's only safe to do so pre-operatively. The toxicity profile between the two choices differ, and more the international guidelines are in favor of pre-operative radiotherapy. But if you want to know first the margins you're going to get, then obviously you take the tumors out first, because this specific case, it was relatively small, it was quite superficial, so you had hoped you could get away with surgery alone, but time told that a patient was submitted for post-operative radiotherapy and yet recurred locally, and obviously this occurs.
Yeah, I agree. This was, I think, also the reason. I also think that the dermatologists who first operated on didn't expect that diagnosis. They just thought, I don't know what they thought, but they just thought, oh, well, as we know it from surgeons, Piotr is also on, if in doubt, take it out.
I agree, absolutely. So, but what is fascinating that it's really some kind of unpredictable behavior, and we cannot still say, even if we are doing such sophisticated examinations, what will happen with this patient. So probably we'll have some entities which we cannot even well distinguish or give the name, but this is why we need to collect such data, and this is the only option. So
Yeah, but it's a good chance if we collect more of these cases. Then perhaps one day we can learn more about these
absolutely
patients, and what to do, whether to
I wanted
radiate.
to agree with Dr. Haas that, in our practice, we also tend to do preoperative radiation followed by surgery in some, in this location, and also size and so forth. One thing I want to comment on is that maybe it was just not included if it was done, but typically we'll do an MRI first to know the extent of disease, and you mentioned this, all the staging was done, so that would help us to know the extent. And also, with post-op radiation, that's probably 6.5 weeks of treatment, during which time no systemic therapy was given, and giving the patient probably give an opportunity for the disease to spread at that time. So maybe upfront characterization of the disease extent, and then do pre-op radiation. It will give a little bit, tighter timeline for the management.
Yeah, probably this would have been also an approach. The problem was in this case, because it was not so easy, that normally if it's a fastly growing tumor, that then you cannot wait so long for the surgery. So in this case, for example, we hadn't established the diagnosis at time point of operation because it was such a rare entity. And then it takes some time until you get the RNA sequencing results, and until you're convinced that this is really the right diagnosis because it's so exceptional. Yeah, but indeed, it's a good way to take first a biopsy, and then if you've established the diagnosis, to proceed. Then you can plan better. That's true.
Of course, this is normal plan of our action, but first we try to establish the diagnosis, but sometimes we have to decide something even after the preliminary diagnosis that it is sarcoma, and that's all. So I agree that we have to decide, because we can, as in this case, probably we can never get the diagnosis.
Yeah, the problem was that we got this case as a consultation case, And it has been before in 2 different pathology departments, in other places. So then it takes just too long if the tumor is growing fast to wait. So this is then, if in doubt, take it out. What happened?
So any burning questions from other panel members? Otherwise, we really thank you, Eva, for this exciting case. Awesome. Thanks for your contribution. So we go to the second case. Mohamed, do you want to start your presentation, please?
Yes, hello everyone. It is my pleasure to share my case and our experience in Cairo, Egypt. And thanks for the Swiss Sarcoma Academy. This is a little bit story of our country. This is the Great Cairo. The Nile is divided it into the east and west. East is Cairo, the Little Cairo, and the west is Giza. The Cairo is divided in a 5 major area. The central area called Abbasiyah, in which our hospital, Ain Shams University, is a tertiary hospital service and give to about 2.5 million population in this small area. As you see, only Cairo has a very dense population, people per kilometer, in compared to other part of Cairo. And now I will start my case. It is about an oligometastatic case. It is a 71 years old female, diabetic, controlled by oral hypoglycemic, HCV positive, and treated with antiviral therapy 2 years ago. She had a history of left breast cancer 6 years ago. For this, she underwent breast conservative surgery and adjuvant radiation, hormonal therapy, because it is a small luminal A, and hormonal treatment was for 5 years and kept in follow-up. He has a family history of breast cancer for sister and aunt. 5 months ago, she complained from the right thigh mass and with a progressive course. She sought with her oncologist from the breast unit. He asked about the PET CT scan, in which he revealed a right thigh mass in the vastus intermedialis, 16 plus 11 plus 7 centimeter with SUV 4. With right pulmonary nodule, largest 3.4 plus 2.2 centimeter. With adjacent small nodule 5 millimeter and another one in the left perivertebral area, so it is only total 3 in number. This is the PET CT scan. This is a thigh mass in the vastus intermedialis, and the lung, the first 2 lesions in the right middle loop, and this is the 3rd lesion in the paravertebral left loop. We did MRI, which saw the right thigh large lobulated mass in the anterolateral aspect, which measurement 9 plus 7 plus 17 centimeter, with high, intermediate signal in T1, heterogeneous signal in T2, with a central necrosis and the displacing but does not invading the neurovascular bundle. This is also an image for the MRI, if it's seen clearly. This is a mass. It is displacing only the neurovascular bundle. Also, this is a sagittal view of the mass, which showing the peritumor edema and the so-called tail sign in the MRI. We also did a Turcotte biopsy, in which she showed a spindle cell neoplasm with a myxoid background, immunohistochemistry showing the negative for BAN-CK and S-MAIA and Desmin, STAT6, MDM2, and positive for S-MAIA focally, CD3 positive. The final diagnosis was myxofibrosarcoma grade 2, and the biopsy from the lung revealed spindle cell neoplasm. This is slides of the immunohistochemistry with a focally positive with SEMA and CD34. So we are dealing now with an oligometastatic myxofibrosarcoma to the lung. Patient has a previously history of breast cancer. How do you want to proceed? First, by preoperative or neoadjuvant chemotherapy. Second option is give a preoperative radiation. The third is proceed for the surgery in the primary and the lung, and or to use the combination preoperative and surgery. I will go to the evidence and lead the panel for discussion at the end of my case. As you know, that the evidence of metastatectomy is described as early as 1914 by Alexander et al. They reported a favorable outcome for surgical metastatectomy in a case even of the metastatic cases. Also, there is a terminology of oligometastatic. He considered an intermediate stage between the localized and the widespread in metastasis. The oligometastatic, if you can treat it with a multi-tools surgery, radiotherapy, chemotherapy, you can aim for a cure of such a disease. There is a different lectures about a definition of the oligometastatic. In number, is 3 or 5. It is limited to one organ or limited to a number of organs. I share the experience of the data in the lung metastatectomy in the soft tissue sarcoma. There is an approved clinical benefit in the lung metastatectomy in the term of the 5-year overall survival. The data ranging from improving survival from 32% or up to 52%, which is much superior than when treated with a multi-agent chemotherapy alone. Also, it is a nice experience to share that the ECN experience from Germany. They publish data of pulmonary metastatectomy of cases of soft tissue sarcoma, about 300 or more patients. If you see the numbers here, the most common number is 1 to 3, 80%. But they can resect for up to 9 in a 10% and up to 10 non-nodules metastatectomy in a 4% of the cases. They also treated a bilateral disease. They also treated a metachronous disease. They also did a lymphadenectomy disease. So the term of oligometastatic, the definition, it is not mere in a number or in a limited organ. It is also depending on how the experience of the team you are treated with. If the experience of the team is well and have a very large learning team, he can do even more than 3 or 5 nodule metastatectomy at time. Also, I would like to share the data from the Mohamed Soren Kettering Cancer Center, who published that the synchronous metastasis has a poorer prognosis than the metachronous metastasis. Also, when the latent period, the more the latent period of relapse, the better the prognosis, as we see in the chart. So, if we go for the preoperative radiotherapy before the surgery, which type of fractionation do you use? Do you use the hypofractionation or the conventional fractionation in a 25 fraction? As we all know, the standard of care, the adjuvant radiation is the standard of care of the most of soft tissue sarcoma. It is either given in a preoperative or a post-operative situation. The preoperative is the preferable because the treatment volume is well defined, as we see in this imaging, but there is carry a risk of delayed wound healing in acute complication. But the post-operative had a benefit that the entire pathology specimen is available. The final margin is available. But again, as you see in this image, the target volume is less precisely defined. And the more volume are taken and the more late complication expected to be have in this area. So if you see the most of NCCN and the European guideline prefer the pre-op radiotherapy than the post-operative radiotherapy. Also, I see the backbone trial in ICSR2, the Canadian trial, who comparing the preoperative versus the postoperative radiotherapy. As you said, in the term of the local recurrence and the overall survival, there is no difference in the statistical significance, but there is an a difference in the term of acute wound complication rate. It's more in the preoperative radiation in a 35%, but the preoperative radiation carry less late complication in the term of fibrosis, edema, and joint stiffness. So this is most of the guidelines prefer to give preoperative radiotherapy than to give the radiotherapy postoperatively. I will now discuss about the rule of the hypofractionation. As you know that when we give the conventional fractionation 2 gray per day, we are using the 4R for fractionation, and we depending on the reoxygenation in the area of the hypoxia the first time. We give time for more reoxygenation of this area, and this area when become oxygenated, the radiotherapy will more effect in it. The story is different when we give high dense or high dose perfraction in a hypofractionation. Here we deal with the hypoxic and the oxic cell. We also destroy the neoangiogenesis, and we can kill by this single high dose the tumor cell directly, what does not depending in reoxygenation. It is also has a role in immune stimulation and carry immune related radiation response. I try to summarize the systematic review about the using of the hypofractionations protocol. As you see, there is a different protocols, 5x5 or 40 gray in 8 fractions or 30 in 6 fractions. Some data using with concurrently with radiotherapy, some using it as a radiotherapy alone. But if you see, the wound complication, in fact, is, as the lecture, is between 33% up to 24%. This is the least wound complication in a 25x5 fraction, and the 5% in 28 in 8 fractions. In the term of the local recurrence, the early data in 2014, there is more local recurrence appear in the hypofractionated than the conventional fractionation, but later on, the most of the data, the local recurrence is similar to that of this conventional fractionation. Also, I will discuss about the rule of using the adjuvant or neoadjuvant chemotherapy in such oligometastatic disease. I know it is difficult to comparing the data of a localized disease, and I share the data of the adjuvant chemotherapy. As you know that there is an EORTC testing the role of adjuvant chemotherapy in high-grade soft tissue sarcoma. They give 5 cycles of anthracycline-based chemotherapy. There is no significant difference between the adjuvant or no adjuvant in the term of the disease-free survival or overall survival. The Italian sarcoma group show the term of benefit in disease-free survival or the overall survival, but the updated long-term follow-up, the overall survival does not reach the statistical significant difference in intention to treat the population. Also, the meta-analysis of the using of the adjuvant chemotherapy is felt there is no improvement in survival in the term of using doxorubicin alone. It can reach overall survival statistically significantly when we use doxorubicin combination. So we depending on localized disease in the histology, is it chemosensitive or not, in the normograms, on the score of the calculator or BRISEC calculators. Also, I share the data about the neoadjuvant trial. I know this trial is testing chemo versus chemo, histology tailored treatment versus doxorubicin ifosfamide, and this trial was negative in the term that histology tailored treatment does not improving the overall survival, but it is give us a signal that the role of the neoadjuvant chemotherapy can have a benefit in the term of the overall survival. And finally, our MDT thoracic surgeon discussed with us this paper observational study about if you gonna use chemotherapy in a metastatic cases of sarcoma, can we give it or post-operatively? They observed that The factor that affecting the impaired lung function is the bilateral resection, which is reduced the spermectomy value, and the only post-operative chemotherapy which is reducing the diffuse capacity of the carbon monoxide or the diffuse coefficient capacity. As you see this graph, that the using of the chemotherapy pre-metastatectomy does not affecting the carbon capacity, and if you use it post-operatively, the statistical significantly affecting the DLCO. So this is from the last ESMO Ligano by a presentation by Dr. Wasi. They share the guidelines that the standard of care in a case of the metachronous lung disease in a soft tissue sarcoma is surgery, especially if the disease interval is more than 1 year. But in a case of the synchronous disease, it is preferable to give chemotherapy, then go for surgery based on the response. Back to my patients, we discussed all choices, radiotherapy before the surgery and the use of chemotherapy or not with the patients. And we discussed finally to give preoperative chemotherapy anthracycline based for 3 cycles, then preoperative radiotherapy hypofractionated 5x5, then go for surgery. The patient received the 3-cycle chemotherapy and the PET-CT scan show favorable response in terms of lung nodules. There is decrease in size as well as SUV activity. But the extremity soft tissue mass, almost stable disease, more or less metabolically active in after chemotherapy. We give hypofractionated 5x5 in a 1-week radiotherapy. The patient tolerated it very well. Then we do surgery after 2 weeks. They underwent white local excision in 17th of February, confirming again the myxofibrosarcoma with all margins are free. Then 2 days before this meeting, the patient underwent metastatectomy from pulmonary nodules. So my take-home message, oligometastatic soft tissue cases is challenging in terms of definitions as well as selection and what is the best prognosis. Uncertainty regarding the plan, you can start with radiotherapy and surgery, or you can add chemotherapy based on the panel discussion, I think. And finally, it is a hint that Egypt is a very large population. It is difficult to have a center of excellence in a soft tissue sarcoma. And instead of that, we try to create the so-called Egyptian sarcoma network, which is connecting the different sarcoma network from Egypt, from Upper Egypt, Middle and Lower Egypt. And we make a monthly meeting series that challenging cases with our pathologists, with our surgeon from the 2021. We have a challenging that we are a very big population. We have a big data. We have a big case report, but we should improving our pathological confirmation. We should improving our data to be involved in an international clinical trial. And lastly, thank for Dr. Bruno for giving us the insights to creating this network, and for his great support and accepted to share the Egyptian cases in his Swiss sarcoma database. And thank you.
Thank you so much, Mohamed, for this really fascinating case. And I think you put already a lot of literature into your presentation. Maybe you can switch again the screen.
Yeah.
I'm now interested to see, how at the different, let's say, sides of the panel members, how we share, how we approach these cases. Maybe the first question to our pathologist. Myxofibrosarcoma, oligometastatic disease, what are your comments in this respect? Is this a different disease? Or oligometastatic per se? Or for myxofibrosarcoma, we had this oligometastatic in October, a webinar on this. We had in August on the fractionation of preoperative radiation therapy. I think there is more background, and today I really want to take the opportunity with your case presentation to see, you know, what are the practical thoughts and how you handle this at your institutions. Maybe Eva, Gunhild, what's the pathology side?
Well, when I saw the pictures from the tumor, I was just thinking that the major differential diagnosis for these tumors at the extremities is MDM2 amplified liposarcoma. So probably I would have done a FISH analysis or so to exclude that. However, it wouldn't change too much about the treatment. We have these discussions repeatedly with our oncologists whether we should have a pre-op radiation or not.
Yeah.
And then always, if I say that in the tumor board, they say, well, but there is no evidence that this is really useful. So, I think it's a little bit because they are conflicting data, as you pointed out very nicely. There is still not a consensus, at least this is my impression, about whether this has to be done or not. And if the surgeon says, well, I can get it out without taking nerves or arteries or whatever, so with not too much morbidity, then they tend to have operation first. Although I know Rick is now breaking down together. Is not convinced that this is the right approach. I think every center is somehow a little bit individual about that.
Rick, it's your turn. What's the approach in the Netherlands?
Well, in the setting of synchronous oligometastatic disease, which obviously is the case within this patient, the idea of doing preoperative radiotherapy has two advantages. One, it is part of the treatment, probably necessary for a large, deep-seated, intermediate to high-grade disease in which the local control or the local failure rate is about a factor of 2 to 3 lower than by surgery alone. And on the other hand, if you do the radiotherapy preoperatively, it will buy you time. The preparation and the performance of radiotherapy will take some, let's say, 2 to 3 months if you give 50 gray in 5 weeks. Then you have the time to do a re-evaluation of the disease in the lung. If that is stable in the sense that you do not find any new lesions, and probably you will find that the ones you already know have grown, that you take into account with a choice like that. If you don't find any new lesions, you can go for surgery of the primary and a local treatment, whatever, cryosurgery or stereotactic radiotherapy of the lung metastatic disease. The buying of time will show that you will select out a subgroup of very aggressive nature with multiple new metastases after 2-3 months. And if you find that, then the intention of preoperative radiotherapy then turns over into a palliative radiotherapy by which a dose level of this will control that disease for 9 to 12 months.
What about systemic treatment?
Yes.
How do you time that in your institution?
Yeah, obviously a patient like this would start with chemotherapy first. I wouldn't call it neoadjuvant chemotherapy in this setting because there's already metastatic disease.
Yeah.
So I would call this palliative chemotherapy, and then by each stage the patient goes through, and first stage would be 3 cycles and then do response evaluation. And in case of response, continue. In case of no response, the situation is even worse than it was from the beginning.
Speaking to radiotherapy, Meng, what's the approach in your institution at Mayo?
So if we just talk about radiotherapy, so there are 2 parts. One is treating the lung metastases, and the other one is treating the primary disease. In our institution, we tend to do more preoperative radiation. I agree with Eva, that's entirely institutional preference and surgeon preference. not entirely, but the trial doesn't really say one versus the other, but I would say in this case, because it's a proximal thigh, there's more wound healing issues. So you could argue for a post-op radiotherapy, but in our institution, we still do pre-op. And we don't have a 5-fraction regimen study. Standard is still 5 weeks, 25 fractions, like Rick mentioned, but we have a moderate hypofractionated study with 15 fractions, so 3 weeks of treatments rather than 1 week or 5 weeks. So I think in this case, if I really worry about her wound healing because she had diabetes, a history of diabetes, I would probably not do that 3 weeks or 1 week. But clearly she didn't have that issue. But then, for the management of lung tumors, surgery or combination of surgery or SBRT, I think it's all appropriate. I would do surgery for that big lesion because that was really large. But with chemo, that clearly got better. But then the little one, you could do either surgery or radiotherapy.
And how would you time systemic treatment?
So that's, again, somewhat controversial and institutional biased. I would say in this case, like Rick mentioned, if there's no lung metastasis, then they may not do neoadjuvant chemotherapy. But since there is clearly metastatic disease, I think starting with chemotherapy is really appropriate.
Thank you so much. Piotr, how do you handle this in Poland?
Oh, it's nothing specific to add because, of course, this is metastatic disease. So also we'll start from chemo, probably will combine with radiotherapy, as Rick suggested, because what are the advantages? First, of course, we see the behavior of the tumor. Second, we also see the reaction to the chemotherapy. This is important because after radical treatment of the thigh tumor and lung mets, we can decide should we continue chemo or not, because this is not a purely preoperative treatment like Rick mentioned, because for preoperative treatment, usually we'll use only 3 cycles of doxycycline, if at all, because this maybe only radiotherapy would be used in it would be not metastatic disease. But for metastatic disease, if we have response to the therapy, probably we'll continue chemo to the 6 cycles postoperatively, because it's a different story. This is if we'll have the response in lung mets, especially because this is clearly metastatic disease. So generally, systemic treatment has still major role, not only the surgery. So of course, for oligometastatic disease, we do everything to maximize the effect of combined treatment. This is why we are probably the most aggressive, and also doxycycline is giving the highest responses to the chemo. This is not doxo monotherapy or something, because we want to achieve the response and to see the clinical behavior of the tumor. So probably chemoradiotherapy preoperatively, surgery, and depends on the response to chemo, will continue chemo or not postoperatively.
And you make a difference between oligometastatic disease and plurimetastatic disease in terms of...
Oh, in purely metastatic disease, we'll wonder if at all to operate the primary tumor, of course, because it's so, and maybe we'll use only chemo plus radiotherapy if it will be symptomatic disease. That's all.
Are there any instances you do not address the primary tumor surgically? If, let's say, there is a...
If we have potentially resectable disease, we always try to resect the primary tumor. But if it's not resectable disease, probably it will not change the situation with this patient.
Right. So, it's a measure of the local situation and independent of metastasis.
Yes. So if we have unresectable metastatic disease, uncountable lesions in the lung, so usually we do not remove the primary tumor, except the situation with its bleeding in this situation, and we cannot continue the systemic treatment because of the problems with the primary tumor. But generally, we treat the patient with systemic therapy. This is different. Here, it was perfect case for maximizing all approaches, so chemo, radio, and surgery together.
Shintaro, what are the thoughts that you do in Japan?
Yeah, thank you, Mohamed, and a very interesting case. And so for me, basically, this case is anyway the systematic disease. So we will start the chemo we will start the chemotherapy for this patient, and observing the effect of the chemotherapy, and then we will perform the definitive surgery, not only the primary lesion, but also two metastatic lesions, because those metastatic lesions can be rejected, not so with a safer margin. So and radiotherapy, talking about the radiotherapy, and it's very difficult. And if we do the radiotherapy, if we detect enough margin, with enough margin for deep-seated mixed fibrosarcoma, it's sometimes we would avoid the addition of the post-op radiotherapy. But in this case, it's looks like the tricky to reject widely because of the tail signs. So we usually add the post-op radiotherapy for this patient, even in a Japanese doctors.
Thanks so much. Let's go back to Canada. Robert, do you hear us? Maybe you can give your final words.
Okay, good afternoon, everyone. So it's a pleasure to be among such a knowledgeable audience. So I selected a case into which I've been involved through my career in terms of clinical research. And it's a fascinating disease, as you may know. Myxoid liposarcoma is a bit a different entity than other sarcoma, and how they spread, how they manage, how they go on over time, and how do they present. So I would like to illustrate this with this case presentation of a 27-year-old woman who was a prison warden and had no significant past medical condition. And she noticed early on a growing mass in her popliteal area for about 18 months before she consulted her family physician, and for which she was told it was a popliteal cyst without further investigation. So the patient then, in July of that same year, saw her family physician again, was getting a bit more local symptoms, for which she was given some pain meds, anti-inflammatory, and small narcotics. And suddenly, in October 2013, she developed pulmonary embolism, treated in another institution successfully, but nobody kind of inquired why she developed this embolism, until she saw her family physician again complaining of her popliteal mass enlarging, and an ultrasound was ordered. And finally, and ultimately, an MRI was ordered and done in March 2014. So this may illustrate sometimes, you know, the difficult path of a sarcoma patient who are kind of, I wouldn't say neglected, but where the suspicion index is a bit low in some. So this was her mass, just to show you briefly the mass, typical finding for myxoid lipo with a high water content and location, which is often extramuscular in the crease. So like here in the popliteal area, and you can see the femoral vessels very close or at kind of very tight on the tumor, and the sciatic nerve, which is two bundles, which is here. And so those are displaced, but not frankly invaded. and the patient had no neurologic or vascular symptoms. So a biopsy was done in clinic, and typical appearance of chicken wire vessels and lipoblasts and a myxoid background, typical of a myxoid liposarcoma. And perhaps later we could comment with your panel of pathologists about the markers, or especially the molecular studies done for those. In other areas, the biopsy, we found higher cellularity and smaller cell, typical of the round cell component, and that led this tumor to be classified as a high-grade myxoid liposarcoma. So diffuse DTI13 was identified, and I don't know, we do not perform it routinely in my institution. I'll be interested to know if, despite obvious evidence histologically, whether further molecular studies are done in your institution. So she got her biopsy, she got her staging. In my institution, we do chest CT for initial staging for the chest. And for this entity, we do whole body MRIs instead of PET scan, as it's been shown years ago by the Boston group, and we confirmed that the PET CT is not very efficient. And we had a few examples of a CT of the spine that were normal, despite the fact that the patient was paralyzed. So this tumor is very high water content, not very dense, and not very cellular sometimes. So that's the reason PET and CT may miss lesion. So of course, as every sarcoma in most institutions worldwide, I guess, she was evaluated in a multidisciplinary fashion. She was presented at tumor board, and the plan was to go with neoadjuvant radiation therapy. This was before the pandemic. Since the pandemic, we've been more into hypofractionation in 25 and 5 over 2 weeks, so every other day, with surgery a month later. And we have a trial where we give 30 in 5 fraction in every other day period as well. And she got that, and as predicted, the tumor has shrunk a bit, not very significantly here, but nevertheless, it was a bit smaller, and made our life a bit easier for resection. So she underwent a marginal resection 4 weeks later, had a good recovery. There was no resection or no damage to the neurovascular structures. And I wanted to use that case because we kind of looked at this in Canada. I led a study, our Canadian experience, and which remained, to my knowledge, the largest on this entity. And we showed that the risk of course, of the low-grade and high-grade myxoid liposarcoma was different, but local control rate was equally good in the context of radiotherapy. And that local recurrence rate was very low, even with positive margins, in the magnitude of about 7% at 5 years, and with negative margin about 4%. So radiation and surgery kind of cure locally in most instances this tumor. And this was a good thing to know and to confirm that radiation was useful. So you see here the margin on this tumor was very thin, about 1 millimeter, but they were nevertheless negative, and tumor necrosis was about 70%. And you see here small areas of low-grade component with a few remaining viable cells and no round cells, and other area that was essentially all necrotic. So in this tumor, this is often what we find. Tumor necrosis is usually high, sometimes up to 100%, and sometimes, change in volume of the tumor with the pre and post radiation setting will be much different. Recently, we published a study led by Toronto about the marginal resection of this entity. There were colleagues in other countries that were more aggressive with this entity, trying to achieve wide margin like they would do for the myxofibrosarcoma just presented. And we remain convinced that in the context where radiation therapy can be used, you can do a good limb sparing procedure, preserving nerve vessels and some of the muscle more than you would do with other type of sarcoma. So after resection, she was reassessed at tumor board, and we used the kind of standard follow-up figure of every 3 months for 2 years, 6 months for the next 3 years, and then yearly. And there's a big debate whether we should do chest CT for this entity, but usually we do for the high-grade ones. The low-grade, we do only chest X-ray following surgery. And we routinely perform whole-body MRIs every 6 months for 3 years, and yearly thereafter for 2 more years. And thereafter, we stop unless there were issues or questions. And this follows a study we did that we published that we showed that the whole-body MRI is probably the best tool available to assess metastatic progression, especially in soft tissue, in the limbs, in the bones, even though retroperitoneum and the spine might be a site of predilection for early metastasis. We found multiple other areas in the body that would be involved by the first deposit of metastasis, and whole-body MRI is the way for us to go. So to get back to our patient, so she had surgery in toward the middle of the end of March of 2014, and she showed up on the whole-body MRI, the small peritoneal lesion of 1.5 centimeter that was confirmed to be a high-grade myxoid liposarcoma again, for which, because of its size, it was decided not to give radiation therapy, and it was resected in May and found to involve the falciform ligament. In fact, it was not exactly the peritoneum, and the margins were 3 millimeters. In the context of early progression, this was accepted, and you find the tumor here. Sorry for the quality of the slide, but there was a round cell component predominance. In August 2015, on the whole-body MRI on your upper right hand, she was found with progression of a lesion at the L2, L3 interval on the left side. And this was a progression on this previous MRI, where this was either missed or too small to be called a potential metastasis. Yes, you may have false negative early on. We've seen that in a few instances. You may also have a false positive, lesion that are not related to the tumor that may even lead to further investigation. In view of this, her young age, it was decided to proceed at some resection, starting first with neoadjuvant radiotherapy, which she responded well volume-wise, and then she underwent a surgical resection. And you see her pathology here. So on the left, the round cell, more rich component. On the right side, the lower grade of the tumor. And so she had good response. And while she was developing, she was getting her radiation treatment and awaiting for surgery, she developed an abdominal wall mass. Not sure if it was related to the previous one, but nevertheless, another rapid progression, and for which both surgeries were performed at the same time. So she had a stage final resection with negative margins, leaving her with some weakness in her quad on the left side. And she had a marginal resection of her abdominal one, followed by post-op radiotherapy. And you see here the tumor and the nerve root and the vertebrae. So you see the closed margin to the nerve. And the plan was to minimize the sequelae to the patient, but get rid of that tumor that may become problematic afterward. And the tumor was essentially all necrotic following radiation. So what about her subsequent story? She had a recurrent abdominal wall in 2017, for which she underwent surgery. And the same year, she had a left supraclavicular region for what she had radiotherapy. She had a deltoid mass, a popliteal mass on the other side that were all treated by radiotherapy. Then she was found with a left ventricular metastasis in her heart. This was picked up by the MRI, for which she got radiosurgery. And an abdominal mass in 2021 that required surgery. But here she is in 2024. She's stable. She has still no lung disease, never had lung disease. She has a normal heart function following the radiosurgery, and she never got chemotherapy. And here's the CT scan of her chest. That basically you barely see the lesion if you were not knowing the MRI below, which showed the lesion better. And this was an early pick. This patient would probably have died of her disease without the use of an MRI to detect this lesion. It would probably have been missed on the CT scan, and she would have came in symptomatic with quite diminished heart function. So what have we learned, and what was my reason to present this case, is that to confirm the lesson learned previously with mixed liposarcoma, that it often metastasizes when it does to the soft tissue and to bone, but lung metastases are usually a late feature. In our experience of that we monitored about the last 70 myxoid liposarcoma, we had one patient who was metastatic at diagnosis and one who had metastasis first. All the other metastatic patients, the lungs were not involved or were involved after other location of metastasis. We also showed that radiotherapy is quite potent and efficient managing the tumor, whether it's the primary or the metastasis. When it gets complex, whether a patient at high risk should go for surgery might be weighed about the benefit of giving radiation only. That may even cure the tumor locally in some instance. And that long survival, the patient is now at almost 10 years following the initial treatment and 9 almost years since the first metastasis. So prolonged survival is possible. We favor the whole body MRI for the early detection of asymptomatic lesion. We feel that early intervention, especially on metastasis, may be beneficial to the patient and may even prolong survival, like perhaps you can appreciate on this case here. But there's the issue of the false negative and false positive that is following such a deeper investigation. So we have a paper that will be published soon in European Journal of Radiology, and showing that a third of our patients with metastasis developed them after 5 years. So there's an issue with the strategy to follow these patients. The latest I've seen is 14 years to the spine. So we cannot do whole body MRIs on everyone till 15 years. So basically, this is an issue. But when we did the fine lesion with the whole body MRI, it changed management in the patient in the 3/4 of our patient. And we found also, although not significant in this work, that the whole body MRI surveillance improved survival in patient for those who observed the regimen of follow-up, as opposed to those who were claustrophobic, who we could not do such an extensive follow-up examination. So with this entity, I think there's a lot to work still, especially defining the role of surgery or radiotherapy or both for oligometastasis. What about chemotherapy? We know this entity chemotherapy is not that effective. Should we use it more often or less often, or leave it for unresectable, widespread disease? Obviously, we need new drugs to address this tumor, and define the schedule of follow-up with whole body MRI if you believe into it. We just got a big grant from the federal government looking at artificial intelligence and deep learning to predict patient on day one with their MRI to kind of predict, who will develop or who will be very much at risk of developing metastasis, and the others who may not. So thank you, and welcome your comments and questions.
Robert, this is an intriguing, amazing case. I think there are tons of questions. I don't even know where to start. One, because we have radiation oncologists and pathologists here today, I want to start with the questions. How do we judge the different schedules of radiation in terms of response? I'm wondering what the pathologists say here. Who wants to start? Eva, Gunhild, Beata?
Well, actually, myxoid liposarcoma reacts to the usual kind of what we think a usual radiation therapy of 25 time 2, quite typical. So actually, you can kind of make the diagnosis even if you don't know it after the therapy, which sometimes happens. So this is of course changing now with new regimens, and it's a huge difference. So you cannot use those old prediction kind of patterns of response to the new schemata of radiotherapy. I think. I don't know what Eva, Gunhild.
Well, we had a lot of discussions on response evaluation, and I think it's a very open field. The most important issue about it was whether fibrosis is now the most important observation and how to quantify it. I think the more we digitalize our slides, we will have it easier, and also the more we combine our data with those of radiology and other imaging opportunities, because I think just microscope alone and H&E is probably not enough for the future, but we need functional imaging and then correlate that.
But have you seen what's your experience? Because I see now tumors treated with 25 mal 2 and then 5 times 5. They look totally different.
Yeah, true.
So you have to kind of apply your schema to the radiologist what they do because it's absolutely different.
It's not one size fits all, and
No.
this is I mean, if you see we just had a few days ago a discussion on different response schemes for tumors in the GI tract. And interestingly, for every region, whether it's esophagus or stomach or rectum or whatever, in every region you've got different response evaluation schemes, and normally also several. Why? Because people want to have their own name on a regression score, I suppose. No, I'm just kidding. But this is why we have so many proposals, and nobody has found already the Stein der Weisheit. I don't know what it is in English, the stone of
wisdom. Wisdom.
Yeah. So I suppose that we have to work on that. But what in general concerning myxoid liposarcomas I wanted to say is that we all know that myxoid liposarcomas belong to those tumors who respond to everything. I mean, to irradiation, to chemo, to trabectedin, to whatever. So it's really surprising, and I was always wondering, especially concerning the response to irradiation, whether this corresponds to myxoid, to the myxoid matrix, which might, I don't know how, but you make the radiation effect stronger. And I don't know whether, Rick, you have observed whether this is also the same for myxofibrosarcoma, especially the grade 1 or 2, because they have more myxoid stroma than those grade 3 tumors.
We haven't seen that to the extent that you're questioning now, whether the myxoid background of a myxofibrosarcoma responds just as well as the myxoid liposarcomas do. I would suggest we probably will not see it. With respect to the responses in myxoid liposarcomas, interestingly, within the Do-Re-Mi trial, in which we performed 18 times 2 gray and have shown some very nice results there, both with respect to local control and with respect to the pathology. The patients participating in the study, of which we published 79 cases, about 27 of them consented to a repeat MR on day 8 and 16 and a repeat biopsy on day 8 and day 16. Remarkably, and Sukwai Lam, a well-known pathologist from Leiden, has published the result as first author. When you look at the results already at 8 fractions of 2 gray, and the biopsy at that point in time, the hyalinization and the background fibrosis is already there. And it doesn't differ anymore. The definitive resection specimen 6 to 10 weeks later. So the effect of radiotherapy is an early event.
So that would mean that we need not so long a radiation. It's bad for you.
Well, that's an intriguing question, whether we can even lower the doses still further. On the other hand, when you look at it would take another 10 years for a Doremi number 2, stopping at fraction number 8. But that would be a design in which I would put the knife to your throat, Eva, when I deliver 8 fractions of 2 gray, and then I give a biopsy to you, and I would like to know within 48 hours, is the effect already there? And
this is no problem.
Okay, if you can deliver that answer,
Yeah.
then the question to the patient is that if you say yes to a biopsy at day 8, that the effect is already there, we can discuss with the patient, shall we stop or shall we continue till 18 fractions? I solemnly believe that there's no reason anymore to escalate the dose beyond 18 fractions of 2 gray with a local control after 2 years of 100%. And the 25 patients being treated in Amsterdam with a median follow-up now of 61 months. These data are currently unpublished, but I recently looked at them. The local control rate remains at 100%. Obviously, we see some metastatic disease beyond 2 years and up to 5 years, but no failure whatsoever.
The problem is that it's not a problem to make the diagnosis in 2 days because it's an H&E decision. You don't need any additional staining or so. The problem is the heterogeneity, and that, of course, I'm not sure whether it's always reflected in the small, tiny core biopsy. But this depends, of course, on how on the technique and what you did as imaging. I think if imaging, functional imaging, would correlate so good with response as I expect, then it might be that you can also do it without taking a biopsy and saying, okay, the tumor is completely quiet, nothing is working anymore, the tumor, and then you could, yeah.
Unfortunately, the MRs of day 8 and day 16 did not give us the answer, whereas the biopsies did. Yeah, very, very unfortunate.
Okay.
Another aspect about your case, Robert, is very interesting. I know when to use surgery and when to use radiation. You chose a huge but successful surgery for the lumbar region, but you had local control. In retrospect, I mean, just listening, I think, well, you made the right decision. How do you see it in retrospect, and where are your thoughts going in terms of, let's say, metastasis? What to, let's say, use combination therapy, and when only radiation? And maybe we can Rick and Meng again comment on your thoughts.
We use more and more radiotherapy and less chemo, that's for sure, and less surgery too, especially as we're learning into this tumor. I don't know the dosage. There's a nice discussion among experts, and we're not there to predict when enough radiation has been given to be efficient. But we found that we don't always need to multiply the number of surgical procedures as a slow progression will occur. Many of these can be managed, and I think it was maybe an overkill, 8 years ago to address the spine. maybe today we would start with radiation and monitor the patient and see how it goes before jumping on her and being aggressive surgically, especially for that tumor. I mean, obviously the idea back then was that she was young. We wanted to be aggressive, prevent further progression. But now maybe next time, see the heart. She had a metastasis in the heart, and we kill it basically with the radiosurgery.
And I think Rick and Meng, you agree with what Robert said in terms of placing more emphasis on radiation for the metastatic sites.
Yeah, specifically the management of the lumbar lesion was quite at the beginning of her disease course. So I fully agree, Rob, that you, after radiotherapy, continued with surgery at that point in time of her history. What I found very interesting is that you find a devitalized tumor just adjacent to the nerve root, which might be an argument in the future to, if you anticipate an R1 resection even for a metastasectomy, then you can preserve that critical organ by the use of neoadjuvant radiotherapy. So for the future, it could be an idea to leave that nerve in without taking it out.
And Robert, do you have any experience with trabectedin? Did you use it at all, or what was the reason?
In their case, no. We used this is not the first agent we use for chemotherapy in myxoid liposarcoma when we have to use it. But the response we got to it has not been spectacular. So yes, it's useful. Yes, it will delay or kind of shrink some of the lesion, but it usually doesn't achieve cure, And in this case, I don't know. Obviously, we haven't tried it, but we were able to manage several metastases without treatment other than radiation therapy and without the burden of this targeted therapy.
Now, Shintaro, we know that you are more reluctant with radiation therapy. How would you approach such a situation?
Yeah, honestly say that in a myxoid lipo, I'm very willing to do the radiotherapy because it's a very good candidate for radiotherapy, and it can be controlled only the radiotherapy for metastatic lesion. I totally agree with that. And another aspect is that Robert, so I fully agree that this mixed fibrous myxoid lipo has been a very long-term, it required long-term observation, even in the 10 years after the resection. Even in after the 10 years, we can find the recurrent, the tumor having come back. So what is the usual plan for the observation follow-up for myxoid lipo? I think it's a little bit more longer. It requires longer follow-up, I think. How do you think that?
May I ask a question, Bruno?
Yes, Robert, how do you think that?
Do most of the people on the panel use whole body MRI for assessment and follow-up of these patients, or you use MRI spine and abdomen or CTs only?
We use whole body MRI, but it's good to hear that you are following them to 10 years. Is that right? We probably should do that too. Right now, I think we're following them to 5 years, but I agree that sometimes the recurrence can be late.
So do we. We also use whole body MRI. Shintaro?
In our hospital, we combine the whole body CT and spinal MRI because with spinal region, it's very hard to detect by CT.
I may mention that I would, in specific entities, I would always suggest to make even a follow-up longer than 10 years, which is, for example, myxoid liposarcoma, but also low-grade fibromyxoid sarcoma. We have cases where 20 years later, the first metastasis occurs. So it depends a little bit on the subtype, whether you have to expect late metastasis or not.
You mean that the histology-driven follow-up may
Yeah,
be
yeah,
important.
exactly. Yeah.
Yeah.
Mhm.
This is a
A good
question.
term.
This is a great case. It's a
Thanks.
question for both the pathologist and Dr. Haas too. So, I always was fascinated by this particular entity because you see they may have really great response on CT or on pathology, but then you have a metastatic lesion somewhere else so quickly, sometimes very quickly after the treatment. And these were, maybe you would think that maybe it was not picked up before, but they all got staging whole body MRIs. And that I see from the typical traditional 50 gray pre-op treatment, as well as 36 gray pre-op treatment. So I don't think it's related to the radiation dose. But then, there was a study from our own institution. It's a retrospective study by looking at this radiographic changes, those patients who did not get a really great radiographic response, i.e. less than 50% reduction in size, regardless of their pathologic response, they have worse disease-free survival. So it's not local control, still good, but then they have more recurrence elsewhere. So just wanted to hear your thoughts on, and of course, Dr. Turcotte, about, so it's like, is the radiographic response here more important or pathologic response more important? How did the disease spread and when did it spread? Thank you.
Any comments on that? I think that are really fascinating questions that you bring up.
Well, I think, there are many people fascinated by this entity. In fact, there are so many question marks and, we have absolutely no power of, prognostication for, which patient will develop those really weird metastatic disease to the subcutis, somewhere. And I haven't heard about any prognostic markers. I thought, it may be that the translocation subtype or the fusion type may kind of influence. Well, I even suggested it once in some paper. So that's why I still keep on, kind of proving the fusion if it's even if it's really H&E diagnosis. So. And then there is, another problem with those defining of the round cell component. It's also not, I think it's quite subjective. I'm not really sure if, from the pictures you showed, if I went for the round cell component, because it's kind of transitional, and round cell component is actually defined, like myxoid round cell. And then we have this transitional zones and, a larger cellularity. So this is really, this is really difficult entity. So, well, and, if you look in the tumor and, it's a myxoid liposarcoma, so it's not round cell component yet. So round cell actually is defined, you look at the tumor and you have no idea what it is. And then you move the microscope like 5 millimeters further and you have the typical myxoid liposarcoma. So this is a round cell component. So I think there are so many difficult. And then there is again this, response to the therapy. If you have this fibrosis and reduction of the cellularity, this is low-grade tumor. But if you have a coagulative necrosis, this is the previously present round cell component. So this is, tricky.
Yeah.
Yeah, Beata, you're completely right. And I think there are a lot of unsolved problems, especially with this round cell component, because it also how to quantify. It's a 5% cutoff. I mean, come on. And we all know that most pathologists do most of the quantifying until now by estimating, by eyeballing, not by measuring or doing some kind of machine-based quantification. So this already is subjective, and then also, as you mentioned it's a gradual getting more and more round cell like, and the question is when do the cells are close enough to say, no, this is round cell. I have the same problem, and it's very difficult to make that more objective. And then we've got this very, I don't know what to say about it, but this group of myxoid pleomorphic liposarcoma, which makes life even more difficult because those tumors even don't have a translocation. So why calling them also myxoid, which make people nervous because they think, does it belong together or is it something different? Or so I think even for those entities as liposarcomas, where we think we have already some molecular guidance, there's so many unanswered questions. And you mentioned some of them.
Yeah,
No, Robert,
you know,
please.
just want to mention, I know the difficulty, and everyone refer to this 5% component. When I reviewed the Canadian experience, we had over 400 cases of myxoid liposarcoma. Despite the difficulties, when you had a needle, a core needle, or an open biopsy or a tumor resected, if the round cell component was above 5%, there was a statistical difference in survival. So plus, if I understand that when you give the radiation that in post-op, when you get the specimen in pathology, maybe the round cell are gone or the tumor is necrotic. But there was also a correlation between the amount, the percentage of round cell in the biopsy and the ultimate outcomes. If you have 50% round cell in your tumor on the biopsy, your prognosis was much worse than if you had 10% of round cell. Now, we were not allowed to publish that because the data were too soft, so to speak. But nevertheless, this was interesting because I think I'm a big core needle guy, and I do believe that we get probably something close to the truth in this entity with needle biopsy.
I envy you, your radiologist. You know, it depends on the radiologist what the pathologist gets. So you have the right radiologist to make this correlation.
But we often do it ourselves in the clinic when it's easy.
Absolutely.
Well,
Great discussion.
well, thanks so much. At this point, I think I want to take the opportunity to thank Eva, Mohamed, and Robert. I mean, you brought just fascinating cases, and it just shows how many discussions we already had, and I think we could continue. We are well aware that this always takes a great effort. You put a lot of thoughts and time, of course, into this. And I think it's very nice that you share this with everyone, that still are so many people among us and listening to what you have to say and what your thoughts are, shows that there is an interest here. So thank you so much. I also thank all the panel members. It's your time, it's your effort. I think we only can learn from each other. And I think that's just the very nice aspect in this field. I also thank all the participants. Again, please feel free to make any suggestions how to improve. If you want to be part of the panel discussions, please do so. If you want to contribute or present a case on your own, please let me know. We are more than happy to share among each other. Last but not least, I also thank, of course, Eugen's team to make this possible, and our sponsors, foremost, of course, PharmaMar. Thank you so much. It was a great pleasure. I learned a lot, and I hope to see you soon again. Have a good day or night or soon morning, Shintaro.
Thanks all.